Yes. Well, thanks again for the invitation. And, this is, I think, something that I've thought about for a long time. I think really even before my professional career in a weird way, just growing up. And, I grew up in the South. I'm just going to see if I can make this a slideshow here.
Yeah, there you
And
go.
yep, yeah. Everyone see that okay? Yeah, great. Yeah, I grew up in the South, and I was born into a family that was refugees from Cuba, and yeah, I don't know. I always felt different growing up in a southern state, and being bilingual, and how educational practices were done and standardized testing was completed. And lo and behold, I went into neuropsychology, and I've really enjoyed the field, and I've been very much interested in treating and trying to help people along their journey, for when they come and see us in the clinic. And it could be for a variety of reasons. Many different conditions can bring them in, but certainly dementia syndromes is at the forefront. And our measures are often considered the gold standard, and all are the gold standard for assessing cognition. There is a however, and I've been interested in that however, and especially in terms of what are the different things that influences why someone performs the way they do on a test beyond their brain functioning. So I was hoping to just start off today in terms of getting people to, and there's already a couple on there, to click on that link there on Slido and put in that passcode, and just put in different factors that you may think could affect test performance. And I actually started it off with the first two. If you have your phone out, you can just scan the QR code. But just get an idea of what people think could affect their performance. What are some demographic factors that would affect performance on a neuropsychological test? So for everything from IQ testing to your MOCAs and MMSEs. So I'll give you hopefully just 30 seconds or so to respond, and see if we can get some people to type in some things here. And let's see if someone put a chat. Oh, passcode did not work for me. Let me see if I can try that. Okay, oops. Try, instead of the actual passcode down here, just try the actual number, the 1566519. Try that, Emma. So I got a couple of responses here. Ethnicity, SES is definitely true. A couple more people typing. Yep. Education level. Yep. Let's see here. I got another chat. All these literacy, physical disability. Yeah, great. A couple other people still typing. Give a couple more seconds to respond here. Chronic disease. Yeah. Yeah, I think the purpose of this was not so much to correct English as a first language, to correct people, as much as to show the breadth of different things that can affect performance on a test, right? And we're going to dive into a couple of them in depth today. But I think it's really important to start here, right? We're thinking about, okay, here's the gold standard of measuring cognition, right? But what are all the things that affect your performance outside of just your brain functioning, right? And I think we have some shortcomings that we're working towards and acknowledging as a field, but I want to spend a little bit more time talking about some of those factors that I think are really important. So most of you are not neuropsychologists. You may have some experience with giving a cognitive test yourself. And I just want to run through an example of a typical scoring procedure that we would have when we include demographic factors and how it affects the actual overall score. I know Dr. Wolf is on the call and she is a neuropsychologist, but for the vast majority, people are not going to have a good understanding. So just give me a second to run through a couple of slides here and give you an example of how we're using demographic scores in neuropsychological calibration. So even though the MMSE has fallen out of favor, it's still something that's probably, I think it's arguably still the most widely used measure in the entire world. MoCA is taking more of favorability there. And if you're not familiar with this measure, it's a measure that's a cognitive screener that's out of 30 items. And a score that someone may get could be a 25. And while we've used cutoff scores are imprecise and not only not sensitive, but also not specific. So in neuropsychology, we use norms. And norms are taking a set of healthy people from a different, from similar backgrounds, and we're comparing the patient to that normative data set. There should be sufficient number of individuals in that healthy data set to make your inference of, is this a normal score or not a normal score? So if you say they got a 25, they're in your clinic, and you want to say, well, they're 65 years old. Is that a normal score? Yes or no? And for a 65-year-old, that's a borderline score, the 4th percentile. But if you add in demographic factors, you're going to get different results, okay? So using this example, same score, if you put in that this individual is white and highly educated, 20 years of education, that's a clearly abnormal score in the 1st percentile. If you then also put into your normative software, okay, well, they're Latino and they have less education. They have 10 years of education. That score then goes from the 4th percentile to the 14th percentile. And depending on how you're evaluating things, generally we would consider that a normal score. All right, so that's one quick example. I'll give you another one. This is another borderline score for someone who's 65 years old. It's animal fluency. We're not familiar with animal fluency. It's a generation of many different animals that you can think of in 60 seconds. Very, very simple test, but very, very eloquent and sensitive test at the same time. Patients with Alzheimer's tend to struggle with this test, especially early on in the course of the illness. So it's 3rd percentile in terms of the score for age. If you include the demographic factors, lo and behold, you actually get the same difference. For the individual who is white and highly educated, that's a clearly abnormal score, versus the Latino, it's someone with less education, it's not an abnormal score. So if you're like me, you start to wonder, and I'll run through one more example, and I'll give you some other thoughts. The Boston naming test, which is one of the most common tests of naming, where you have them name different line drawings. What do you call this? What do you call that? Right? And if in this example, if you add in their age, it's a 75-year-old, 5th percentile, if they get 22 out of 30. But if you add in just one factor, you just say that they're 75 and Black, it's 21st percentile. So why is this? You start to wonder, why is it in a way correcting for ethnic minorities and giving them more of a cushion, right? Is it because our tests are biased? And norms are a way for us to develop and create more sensitive and specific clinical decisions, right? And we're trying to evaluate not where someone's from or what their background is, but whether or not they have some kind of brain injury or brain dysfunction that is causing cognitive dysfunction. And so certainly norms have become a way for us to reduce bias. But it's still, you're going through these examples and you're asking yourself, well, why is this case? And you may start to come up with some ideas of why, in this case, ethnic minorities are performing a little bit worse as a rule of thumb in the normative sample, and then are getting that cushion in the normative correction. But the gold standard now in neuropsychology has moved away from just using, and this is in adults, just using age alone. We realize that there's all these other factors that you all create and put into the chat box there that can affect your performance, right? Your sex, your education, and lo and behold, also your ethnic and racial background. Even though that is very much become the gold standard, just based on that simple exercise, I think we all came up with a bunch of other factors that are not included here. And then finally, like race and ethnicity is really these general proxy measures. This is social constructs that are non-specific and don't have a lot of scientific evidence in terms of brain functioning. So what is beneath the surface, so to speak, and how do we become more specific in understanding the test performance and the different factors that are affecting it? We've now started to include single word reading, and some can think of that as literacy, or in neuropsychology, we might call that pre-morbid IQ. But still, these at most we're including these various factors in normative correction and neuropsychology. I got a chat here. Let me see here. Oh, no problem. No problem. Thanks for coming, Nikki. I appreciate you being here. And hopefully, we can talk more about some of the suggestions that you had in the chat too. And there are other measures that are coming out, like the ones Nikki referenced, for decreasing the bias, and that's really hopefully the end goal of this topic, of getting to that point. But neuropsychology was marching along this pathway of saying, okay, look, let's see if I can go back here. This is the gold standard. Everyone should be doing it. And it was moving along until really the concussion settlement. And I don't know if people have kept up with this, but this has been a hot topic that has really affected the NFL, and as it relates to disability and payouts. And a part of the payouts happened to be how injured you were. How do you determine how injured someone is? Well, obviously there's lots of medical tests, but one of the criterions was neuropsychological testing. Within that, they had a structured and standardized approach of determining and evaluating people that include race norming, which is what we just went through. The race norming is a way that came about to correct for false positives, but what it doesn't do is correct for false negatives. And certainly, it is very much a proxy, right? Why do we even care about race when it comes to test development and actual test scores? And more than likely, race and ethnicity is getting at various factors that are a part of that proxy measure. And maybe it's acculturation. Maybe it is, somewhat literacy or psychosocial stressors that they are experiencing more oftentimes than not than their majority counterparts. Maybe it's their financial status. And so this is a group from University of California, San Francisco, who came up with the idea that, look, okay, let's move away from race norms and let's dig down and try to figure out what is the actual determinants for brain health, and let's be more scientific about that. So they came up with all these suggestions and different ideas, and as a field, we're now moving in that direction. There's been different position papers from different organizations that have suggested this is a really good idea and we should do this. But the norms that we use in clinic every day and the tests that we use in clinic every day are not there yet. And certainly there's some suggestions in terms of different tests that are less culturally biased and so forth, and we'll talk about those. But generally speaking, we're just not there yet. So if you had to take all those different factors that they came up with, you might group them into 6 and maybe even 2, right? Okay, well, if you think about all those different things that can go into what makes an ethnic minority or racial minority perform differently on these tests. Maybe it has to do with the educational quality. Yes, we capture education, but it's a total number of years. It's not the quality of education, right? Well, maybe it has to do with their language, right? Their language, are they bicultural? Are they bilingual? What about their economic and maybe financial status and where they are and what neighborhood they live in? So I want to focus today in talking about acculturation and neighborhood as the main factors that I think are important for us to focus on in understanding neuropsychological test performance and overall brain health. Just to define acculturation, if you're not familiar with this, it is not the same as assimilation. It's very much related, but assimilation means going from one culture to another, right? And actually usually means minority culture. By definition, it means minority culture to my majority culture. In our case, in the US, it'd be going, at this point, things are going to change, but at this point, it'd be going from a non-white to white. And acculturation is a bidirectional process in that your current culture and what you've come from is interacting with the majority culture. Okay, and it's a very complicated process, but it's influenced by many different factors. How do you identify? What's your ethnic identity? What types of things do you like to watch? What type of things do you like to eat? What language do you tend to prefer to talk in? Who do you tend to associate? What are your friends and family doing? And so it's very much this bidirectional process that is complicated and very much moderated by various factors. But at the end of the day, when I talk about in this presentation, the more acculturated you are, what it means is the closer you are to this majority white in the US culture that we have. Right, so these are the things we brought up, and we're talking about why does this matter? Tests don't matter where you're from, right? This is the gold standard. They're not culturally biased. Whether it's the world we're talking about or DC, right? It shouldn't matter. I think the shouldn't is the important part, and the other part is just by that simple example of that I provided you with those neuropsychological test scores. You see it does matter, who you are. And so we're going to walk through that. Ultimately, I think what's important and what neuropsychology can offer is the gold standard of cognitive assessment in clinical settings, right? We help with differential diagnosis, whether it's a more mild condition like ADHD or something more severe like Alzheimer's disease. We can hopefully help with things like, can this person work? Yes or no? Can they live by themselves? Right? Do they need accommodations or supports? Right? Are candidates, are patients good candidates for surgeries? And ultimately, I think, whether that's for epilepsy or Parkinson's disease or other types of conditions, even OCD, right? We have very reliable and valid measures, but are they the same? Are they culturally equivalent for everyone? And I think we've learned over the years that the answer is no. And I'm not going to spend so much on why it's come to that point as much as focusing on your acculturation level and how it affects test performance, as well as where you're from, especially in terms of your neighborhood. But if you're really interested in learning about the why, I do think it's worth a read and investment, but some would argue that it was no mistake that cultural minorities perform worse, right? There's a good amount of racism and oppression that is rooted in psychological assessment. It's a very unfortunate part of psychological assessment's past, especially in the US, going back to Lewis Terman at Stanford University and the development of IQ measures when children who were from non-white backgrounds were performing worse. There was conclusions that they were just intellectually inferior, and so in one sense maybe you can say it was ignored, and in another sense, and it was actually a method that people were used to actually oppress others. So I think it's worth acknowledging, and I just for time constraints, I can't spend a lot of time on that. And it's a very interesting topic to look into. And I think there is some precedent for why cultural minorities don't perform as worse. It goes back to how the tests were developed, right? and the items that come onto those tests. Who's the sample they're using? And so we became really interested in thinking about acculturation or test score, I think, simply because when a patient comes into the clinic room and they're referred to us, if there's in a clinic notes, oh, they're not a native English speaker, then there's an obvious, oh, okay, well, the non-native English speaker, or they need an interpreter, or they only speak Spanish, is going to influence their test results and the test that we have to use. We have to be very thoughtful about that. But what about the individual who speaks multiple languages? What about the individual who English is still their dominant language, but they are bicultural and they grew up differently than what would be the quote unquote typical majority culture here in the US? How do those individuals fare? And I think the focus has always been on the people with the non-dominant English language when we think about culture and bilingualism. But there is some merit about this acculturation construct, even in the absence of the language confound. And when we looked at the literature, we found that people who are less acculturated don't perform as well. They don't perform well really across the board, whether it's a language measure, whether it's a test of attention, whether it's executive functioning, orientation. It's kind of like a you name it, they don't do as well. And so we wanted to do a review of this and see what it took, where it took us. And so we did a systematic review, and we ended up only looking at a healthy participant. So we had a pretty small N in terms of the number of records. We got down to 9 records. And it's a narrative review. So I'm going to show you some data, but there's a couple tables that we have in the manuscript that I can't provide just for space constraints. But just to review kind of the general finding, it's what we found in the initial studies before, which were, people who are more acculturated generally perform better across the board, whether that was a test of IQ, processing speed, attention, executive functioning, language, and memory. Now, there was some variability, and we're still kind of sifting through that, but that was the general main effect finding, okay? If you're interested in some of the correlations, they're presented here. Some are and you can see they're positive correlations and some are negative. The negative are ones for measures that you would expect. So for example, this one is years educated outside of the United States. So the more you're outside of the United States in terms of your education, the worse, and this is a correlation, that you would perform on one of the IQ measures, in this case, the verbal intellect score. Okay, so they're in the direction that you would expect them, and it just depends on what the measure is and how it's computed. And all these correlations that are presented on the slide are significant. So even the smaller ones, like the 0.17, is still significant. And this is interesting because that's a dementia screening measure. All right, and so I think a lot of people think, especially like this measure, okay, there's gonna be no cultural bias here. But you can see how pervasive this issue is, and this is just correlations, and so take that with a grain of salt. But looking at even regressions, and so when you're controlling for demographic factors that we talked about, age, sex, education, and race and ethnicity, what are some things that still predict in terms of acculturation? And these are standardized beta that's presented to you, and so you can have an idea of the degree of change in the cognitive measure. But again, you get very similar findings in that it generally is pervasive in terms of the different types of measures across the board. And I think it speaks to the idea that this is something worthwhile to focus on. This is not something that we should just completely ignore. I'm happy to answer any questions about those, but I think for me, where this takes my thinking is then, right, the why. Why is this, right? Why do people who are less acculturated perform worse? And we'll talk about a few potential reasons of this. The first is, I think, one that's dismissed a lot, or maybe not talked about enough: examiner-examinee factors. So what I mean by that is, does your demographic background match with the assessor? If yes, and you're a cultural minority, you're going to do better. right? When there's a match, it tends to be a protective effect against when there's a non-match. And this is kind of a rule of thumb, and there's some nuance to it. But as a general rule, let's say you're an African American and you're coming in, you're being assessed by a white assessor. Generally speaking, there would be a negative effect of that non-match, versus if that examiner is also African American, there would be a protective effect. And this has been shown on in kind of the educational literature and educational testing a while ago. And some people have followed up on it, but it hasn't really been something that's been a major focus, I think, within psychological assessment, at least in training programs. And as we talk about things, there's an interesting study that's done by a group in UCLA, and what they end up doing is they took African American and white and Caucasian, and this is an experimental condition. So there was a manipulation of threat and then non-threat. And what they found was when they manipulated the condition, there was an interaction between race and threat. And so generally speaking, the African Americans performed worse when there was a potential threat, and this was a stereotype threat, and they induced this with the assessment. Now, what was really interesting is there was this protective effect that even when they were in that condition of the stereotype threat, the individuals with high perceived discrimination were protective when they were assessed by an individual of the same background. So, right, this is African Americans, okay? And so if they're high perceived discrimination, this is just a rating scale of just general life of how they have perceived discrimination based on their appearance. And if there's a match, it very much protected against this major effect that you got. Almost, it's over a standard deviation in the Z-score for learning and memory when you had a mismatch. So it's food for thought that I think examiner-examinee factors are relevant, and it's not something that we often, I think, focus on, but it's something that we're interested in looking at further. And we have a clinic sample that I'm going to talk to you about, and one of the graduate students that's doing the practicum is interested in looking at this. So I'm very intrigued, right, of how this could be a potential effect and how people perform. Why is simply because this is not accounted for. I think there's probably an understanding of we try to be inclusive and not create a threatening environment. And so hopefully that should be helpful. But I still think even by being inclusive and not creating a threatening environment, there could still be some threat that is perceived from the individual by systemic racism that maybe not all of us have experienced in our life, but they have. The other aspect, that goes into acculturation, even though we're holding language constant, we think, right, because they're fluent, these are fluent English speakers. Generally speaking, those who are less acculturated tend to have a language effect. And so there tends to be an effective language, especially for those who are bilingual. So even those who are bilingual and fluent in English, and let's say Spanish, their overall performance is going to be worse on tests of language in terms of vocabulary, verbal fluency, and naming. And this is just a study looking at children and showing this effect. And it's almost a standard deviation. So it's a pretty significant effect early on. It gets smaller over time. But what's interesting is people have shown that bilinguals will know more language in terms of you add both languages together. But if you look at just one language, in the case that we're doing our assessments for, in this case, bilingual American, we're going to do it in English because the measures are generally better. There's still an effect. There is still an effect of their language on their overall performance. And simply put, they know less words. And this is a vocabulary test. It's a picture vocabulary test. So language very much has an effect in acculturation, even if, let's say, you're a dominant English speaker, but you also speak another language. that individual generally is going to perform slightly less on language measures than someone who is an only English speaker, a monolingual speaker. So the whole bilingualism literature is super fascinating and plays a role here in terms of acculturation. And you ask yourself, well, why is language, affecting their performances? And we think of, I think the brain is this infinite resource, but in reality, there's a finite amount of resources for stuff to be stored in the brain. Right? So there's this language system competition that can happen, right? There's only so many rooms, and metaphorically speaking, for language to be stored. But at the same time, your English ability tends to be a little bit worse. And this is a rule of thumb, so it doesn't apply to every single individual. If you yourself are bilingual or trilingual, and you're thinking, well, my English is pretty good, it might not apply to you. But as a rule of thumb, this is true. And so why would a bilingual Latino, for example, perform slightly worse on some of our measures if they are fluent in English? They might not be speaking it as frequently as you are if you're only speaking English all the time, right? You're having greater exposure to more words. We know that ethnic minorities have a higher concentration in educational systems that don't tend to have as much resources. Certainly that could play a role, right? The frequency of the item, right, is an important item. Is an item culturally fair based on the frequency of how often you see it in one culture to the next is another idea, right? So, this is a pelican. In Spanish, that's a pretty common, Latin America, it might not be too uncommon, but if you grew up in the mountains in the middle of South America, that might be a very infrequent thing. Harmonica, harmonica may be much less frequent, right? And so most of the tests that we use in neuropsychology were developed with an North American bias, right? What is common for us and here, and people have translated tests to different languages. But how the test is developed and whom it's developed on plays an important role of why we're in this conundrum of having to correct for who an individual is and where they're from. So a lot of people said, okay, well, language tests, it makes sense. They're biased. Don't use language tests if you have, people who are less acculturated. First of all, that's a really hard ask because so many of our tests are language-based. How we communicate and evaluate almost exclusively depends on language. And certainly there are, quote, nonverbal tests. But if you're looking at this item, any one of these, I wonder what your brain is coming up with. Is it coming up with 4 lines together that's blue, or is it saying it's a blue square? Right? And so even when there's nonverbal things, we're still using language to evaluate and encode information. And so there, yes, the research says there's a smaller effect, but it's not language or culturally free. I mean, just think about Hebrew and Arabic. How do we, we read English and Spanish left to right, but not all languages are read that way. Okay, so even if you do a nonverbal test, maybe our eyes start here and go here, right? If you grew up speaking Hebrew and Arabic, your visual exploration of the page may be slightly different, right? And so there's subtleties that the language factors can still infiltrate and affect your actual processing of the information that when you're doing the test. And a final factor that I think is relevant for acculturation is this whole idea of our educational systems and our importance of placing on time. We have lots of tests, and I think there's some movement and desire to go away from that. Some maybe for the good reasons and some maybe for concerning ones. But end-of-grade testing, I think we can all think back to, if you're educated in the US, think back to when you were a kid in elementary school and in middle school, you had end-of-year testing. You always had this time-based testing. Even your standardized tests that you're doing in the classroom have time limits, right? We value being not only accurate, but also being very quick and efficient. it may not be the case like that in all of the countries. Right? Think back to those correlations and the regressions that showed that the more you're educated outside of the country, the higher the effect was in terms of your performance, and generally in a negative way. So there's been some interesting work on this, not a tremendous amount, but this was a study of comparing Russians and Americans, and what they found was the Russians performed worse on processing speed measures and executive functioning measures that were quote unquote nonverbal measures. And they also tend to value time less. And they specifically, there's different time factors, and they evaluated what the time factors were, but specifically it was planning and punctuality. And interestingly, the time valuation for the Russians mediated the difference across these score performance differences, right? So when we're sitting down and we're timing somebody, how important is it for them to finish quickly? Well, that is going to depend on a lot of factors, but especially how much do they value these things? You know, I don't know if you have cultural experiences yourself, but just think anecdotally when you go to different places culturally, right? And you can think of different cultures maybe are more time sensitive and more uptight and always wanting to do things efficiently, and others less so. So it is something that does vary based on where you're at, right? There's been some mixed findings though, in that Western cultures can actually be worse in some cases, and Asian cultures can be quicker. So it's definitely something still to look into. And I wonder, you know, instead of being just a culturally bound thing, is, you know, maybe thinking about urban centers, right? If you think about different places in the world, and this was a really interesting study going back to the study, the 70s, and they looked at, these are anthropologists, and they looked at different cities across the world in these different locations here. And what they found, which has been replicated in further research, is what they call this pace of life phenomenon. This is just observational of looking at different people in these different cities, is as the population of the city went up, the actually walking speed went up. You know, and so maybe, yes, there could be cultural components to this, but also maybe there could be factors of truly urban size components, right? Where you're at in terms of within your country. Does that matter? You know, I think, you know, where we're going with this, and we'll talk about some future directions, I think the first and foremost is what's happening now, and hopefully, you know, not just with this presentation, but hearing things on the news, seeing in the Washington Post talking about the race norming. I think there's an acceptance of, okay, we got to do better. And most clinicians, vast majority of them, I think, are acknowledging these are factors that influence test performance. But still, what are the action items? How do we move forward? There's been position papers from different neuropsychological societies saying, look, we actually need to stop using race norming altogether. This is really problematic. We need to move forward and actually develop new norms. So there's been a call for this. There's not those new norms yet. And I do think, you know, acculturation and maybe even subcomponents of acculturation, like we talked about, their actual language skills, maybe their time, maybe even, you know, simply put, do the examiner and examinee match, right, demographically? What about other factors? And this goes back to the initial slide. One factor that is really relevant, I think, here is SES, right? Well, where are you from? What's your neighborhood? How did you grow up? You know, this is a factor I think we've seen anecdotally in our clinic a lot. And when I did my fellowship in Baltimore, I saw it tremendously as well. You know, generally speaking, if you think about the US, racial and ethnic minorities are generally from a lower SES. They're less financially secure, less stable housing, they have worse education, less healthcare access. And even though ethnic minorities, especially Latinos, are growing at a really rapid rate, and by 2050, white majority will no longer be white majority. The problem is disparities are actually increasing. They're not decreasing. Disparities in the sense of collection of having these groups in these lower SES bands. And so we have patients from all over in our clinic, and I think I started to see it when I was on fellowship in Baltimore, and why was there so much disparities based on who an individual was and how they performed, regardless of what the brain MRI said, regardless of their medical workup? Why were we noticing this anecdotal performance difference? And we've talked about a couple of them, and I just felt like our norms were insufficient, even when we captured their age and their education, or even their English literacy. We felt like there was still something missing from their test performance that was not explained by their brain functioning. And so we've started to look into some research that's come out of University of Wisconsin, and if you're not familiar with it, it's from Amy Kind and colleagues, and it's the Area Deprivation Index, the ADI for short. And does this ADI capture things that we're not capturing with our typical norm sample? And I think certainly there's cultural factors, but it just felt like there was a little bit more SES anecdotally to the patients and when they were coming in and when we were examining them. And so we've developed a clinical database here. And right now we have about 300 individuals. If you're not familiar with the ADI, sorry, I should this graphic here. You can look up anywhere in the US and they have a heat map. The red is worse, the blue is better. So this is DC. I'm sure you recognize it, but in case you didn't recognize, this is DC, right? So this is Southeast and Northeast DC, right? And then we have Northwest. Anecdotally, this kind of makes sense. This little red spot here is Columbia Heights, right? And so it intuitively makes sense, and it rates you from a 1 to 10 if you're in the state, or in this case, jurisdiction, or there's a national percentile. And for our purposes, what we divided the sample into 5 groups and grouped them that way. And we're just beginning our analysis really recently in the last couple of weeks. We have similar age range, but you can start to see you have a higher collection of ethnic minorities, and the higher is worse. So the higher quintile means the worse or greater disadvantage. And the disadvantage is rated on 17 different census factors that I'm happy to review if you're interested. But it starts off, this is the most advantage, and then this is the worst. But generally speaking, we are a pretty diverse sample. And certainly we have some limitations. One of them I've noticed already is, even for the most disadvantaged, is our education level still relatively high. In any case, we have a pretty decent sample, and we're hopefully by the end of the year we'll have 1,000 people in the sample, and give us a really robust sample to look at this idea that does the ADI, this being where you're from in DC, doesn't matter to your test score. And after you can control for the gold standard here, right, of all the things we already control for in neuropsychological norms, does this ADI factor have incremental variance? And what we found is not only does it have incremental variance to this composite score that we created from 6 domains and 13 commonly used neuropsychological measures, we actually found that in addition to having incremental validity here of overall these factors, it actually mediates the factor of race and ethnicity and education on their actual test performance. So this is exciting, and we're still wrapping our heads around this. And so hopefully, if we have time, I'd love to hear your thoughts, especially about this, but certainly about any of the acculturation. And I think there's really some truth in what we think of the social determinants of health, and how we think of neuropsychological norm correction and its relevancy for future development and new norms, right? We definitely need new norms, but to Nikki's point earlier, and she put into the chat, right? New norms is kind of a stopgap. We need new tests. We need new things to move to. And I do think technology has a role to play in this. I think potentially we can have data even before they come to our clinic room of how they are functioning in the real world, and we can provide hopefully an expert analysis and opinion on trying to help them. There's all kinds of new technologies out there. I'm sure you've heard of Lumosity, and there's all kinds of computerized assessments. One that is backed by science and is very comprehensive is called Brain HQ. Endeavor is actually a new treatment for ADHD. It's a video-based game, and obviously you'd be collecting data on how vigilant and focused they are and accurate. But I do think we're going to move away from the standardized kind of measures of paper and pencil-based testing in neuropsychology, and hopefully incorporate more technology. And it's an exciting time, but we do have some work to be done, and look forward to hearing everyone's thoughts. Yep. So I'll open it up for questions. Hopefully we have maybe I think this goes till 12, so like 10 minutes or so.
Loretta had to step away, but on behalf of the Institute, I'd love to thank you for that great presentation. It really gave us a lot to think about. So if I could kick it off with a question, immediately I go, I think right about the computer adaptive testing or computerized testing, and you hit that nicely at the end. I wonder, what do you think are the critical elements that those need to have in order to be good tests? And what do you think are the limitations of those that we have to overcome?
It's a really good question, and I think there's a lot of money at stake for a lot of people in trying to develop that, because it's a resource thing, right? People can pull up a web page and do a test. It's a lot harder to get into clinic. And so I think the biggest issues, Keith, is reliability and validity, right? And that's like kind of the obvious answer, but like if you do a test on the metro at 5 p.m., is it the same thing as doing it at home or in the classroom, right? And so, yeah, there's probably moderating factors based on the environment is one. And then the validity is, what is it we're trying to measure? So now the gold standard for memory is, for example, the HVLT, right? They're the ones that we are giving in clinic. But maybe it's not that, and maybe it's actually how well do you remember your grocery list when you go to the grocery store, or how well do you remember your future appointments? And so I think there's a validity issue, and what are we considering the gold standard? But I do think the computerized based testing, the two cruxes are reliability and validity, and how do we make sure they're both of those things? Because I think in the past where we've seen computerized based assessment where they've fallen short is both of those. They're sometimes seemingly accurate in what the patient's describing and what they tell you, and then just other times just wildly off.
Thanks.
Yeah.
Nick, I just wanted, my clinical heart was singing as you were talking, because I'm always preaching that you have to be so careful interpreting the testing that we do in the limited capacity in clinic for people who don't have language congruence or are not isolated English speakers, and to speak to the age of when people learn English and then we test in English, right? So many things. And so I'm curious, this is a kind of a pie in the sky question, but as we look to cohorts of people and try to understand how cognition is presented in existing dementia cohorts where language plays a role, how do we look at that data critically so that we can still utilize it, but maybe recognize that it has different limitations? What do we do with that information? And then how do we change our practice going forward, knowing we need more recognition and opportunity for congruence in testing, but we don't have that, right? So if what do we do on a day-to-day? So looking back and looking ahead, what's your dream? What should we do? How do we make the best of the trouble we've got?
Yeah, I don't know. I think you and I both share the same passion, which is trying to care of people the best we can, right? And we have pretty significant limitations, and I think one of the things with research that can be frustrating, especially from a cognitive standpoint, is they will lock into a measure, whatever it is, and they want to give that measure for years to come. And then maybe they'll say, okay, well, now we're not going to give the logical memory 3rd edition, we're going to give logical memory 4th edition, right? And so the degree to advance and change in terms of measurement is actually the opposite. People are pretty rigid and they want to stay exactly to make sure it's the same outcomes that they're measuring. But you bring up a point is, well, we need to change. And I don't know how exactly it looks, especially for outcome measurement and especially dementia trials, especially with all the monoclonal antibody stuff coming out. Like, that is really old school neuropsych measures. And I don't think that will change for some time. But I think as we get new measures in the clinic, like here, then we'll be able to then incorporate it into the clinical trials. I also think that in those clinical trials, they have people, hopefully they're already thinking about evaluating those factors and doing the best they can. I don't think they're neglecting them, but just thinking about some of the new monoclonal antibodies like this, really the lack of representation, right, was a glaring issue. And that's not a new problem. It's like a historic problem. But I think it goes back to what you said. And I think if nothing else at this point, clinically and then also research, is just knowing getting data is the best thing, but sometimes the data is biased and we have to take a test score with a grain of salt. And like you said, it's a test score is just a test score and you have to put it in context. And so I think one of my take homes in doing the research is just knowing, okay, if we can't correct it perfectly, at least we can acknowledge it, right? And we at least can try to understand that this feels funny, this doesn't feel accurate. And I think that's really important for our trainees and as they're learning stuff. And so I think pipe dreams, and this is a long answer, my pipe dream is new measures. And I do think that is some kind of technology. And it doesn't mean that all your older adults have to get an iPad, but I'm thinking of things like wearables and, what can we learn about people before they can come to the clinic? And so I'll give you an idea. What about an older adult who start to cooking less complex meals? They start to shop a little bit more simply. They stop going to the busy supermarket. And, this goes to what Keith's working on, I think, a lot of this stuff. But I do think there's going to be patterns from big data that I think will be helpful from a neuropsych standpoint that can then correlate with their actual test performance. But I do think that would be awesome if we can kind of take some of this technology that the world is already gathering on everyone and we can use it in the clinic. So, yeah. I have a couple comments here in the chat. Yeah, definitely. Emma said that, like, yeah, they're going to go there for 5 hours. Exactly. Like, this is super inefficient. Well, I know I parked over here, but you can track how they're driving. Are they driving slower? Are they driving less efficiently? Are they making more stops, right? And so there's a lot of, I think, data out there, and obviously there's major ethical concerns, right? And so we don't want to dismiss that, but I do think at some level that will be very useful to kind of bring into the clinic. And I don't think it means we have to immediately dismiss, your MOCAs and HELTs and all that, but I think that's, I don't know. I think that's down the pipe. Do you think the MMSE should be adapted to generational language as our allergy population shifts? Also, yes. Yes is the simple answer to that first question. Absolutely. Like, one of the most biased thing, I don't know if you've ever given an MMSE, sentence repetition, right? When you ask them to repeat after you, right? Just repeating that sentence. If you just think anecdotally, who gets that wrong? I bet you can think of cultural differences there, right? Or just like on the MOCA and naming those 3 animals, same thing, right? So yeah, I think clinicians, we all feel this. And so, yes, I definitely think it needs to be adapted. Is there a short test for LD populations attention span shift as we age? Yeah, that's a good question too. The length of task engagement, very much true. I think anecdotally, at least with us in our clinic, if it's a super long battery, that tends to be for younger patients, ADHD, learning disabilities, types stuff like that. And the older adults, we really try, even though it's a long appointment, and I know they probably still complain about it, we try our best to make it shorter. And I think actually that's the wave, and goes back to that initial question and answer about the future. I do think the testing, I think it's going to get shorter and shorter in clinic. And I think that's kind of where the insurance wants us to go. And also patients don't want to be here for several hours. And then another question is of whether, yes. So great question, Fernando. the gold standard, people have said, okay, are these American neuropsychological tests. So let's translate them to Spanish. Let's say, for example, the WACE is the intellectual measure. That's the gold standard. We're in our 5th development of that now. WACE 5 is out being standardized. And so what they did is they said, okay, well, actually, yeah, we can't just take the exact test, and we have to adapt it to, in this case, Mexicans and then Puerto Ricans. So the Spanish version for the WACE is those 2 populations. That's it. And there's a lot of psychometric problems with it. And so there's work to be done. One of the biggest problems I see, and you know, you have to be kind of careful with this, is a lot of our tests are copyrighted. And so what does that mean? That the test publisher owns it. And so if it's a lot of money, they're not going to do it. And so that is a concern, I think, for getting better tests out there and how that changes, because ultimately, if it's going to cost too much, they're not going to do it. But people are aware of this and people are trying to work on it. It's just maybe a little bit slower than we want.
I guess another question is, what do you think about as the younger generation gets older, we'll have to adapt tests, like we won't be able to use clock drawing as much anymore.
Yeah.
Because I know I teach clock drawing to 20 or 25-year-olds and they can't draw a clock. What do you think about that aspect?
Yeah, I mean, I think a lot of the tests are antiquated. You know, that the good news is that I think they're pretty reliable and they're very valid in many cases, but the validity is, I think, is losing is decreasing with points you bring about the clock drawing, for example. And I do think we need to adapt it. And so we're moving there, like the WACE measure, for example, is all in our clinic is all on iPads now. And so like I think slowly, but like we still make people draw the ray figure, and like that was in the early 1900s. And so I do think there's impetus to move forward, and there's no one yet really filling the space of what those new tests look like. You know, even like Brain HQ, that's really a cognitive kind of cognitive rehab type thing. It's like, okay, let's do these tests and then let's reevaluate later. And there's a bunch of different paradigms out there for computerized based testing, but nothing's really caught on. You know, traditional neuropsychology is still kind of stuck in the old school test, and so we'll see. I think, and there's a lot of people and trying to work on this, but it definitely is the simple answer to your point. Things need to be updated.
I'll disclose that whenever I use the MoCA version 2.0, I don't feel confident with what the third animal is, right? Like, what the heck is that saying?
Yep.
And certainly as I'm giving that test to patients, I often think to myself, how often were you in a zoo growing up? Like, what is the socioeconomic bias in this test? And it definitely reduces administrator reliability because I'm biased and being flexible if I don't know what the creature is supposed to be, right? Like, there's so much bias in all of this. I just leave that there. Let's not even talk about people who are deaf and hard of hearing, right? And when you acquire that, I mean, there's just so much opportunity to ensure we're capturing people. But then, you know, one of the questions, one of the grants that we're doing, Nick, is if we're trying to be more graceful and forgiving potentially while we don't have good tests that address the many things you so thoughtfully brought up today, do we risk underdiagnosis as we're trying to compensate from an erroneous overdiagnosis?
Yep. Yeah. And that, you know, yeah, I think, you know, hopefully in that norm example, like just the simple norm example, like you take your naming score, and if you just put in whether or not they're African American, it makes a big difference. The flip side is it matters who they are, right? Yeah. Did they grow up in an affluent area with strong education? They went to private schools. Well, then putting that race score, that race normative correction, it doesn't make sense for that person, right? And then it risks the underdiagnosis. So I think it goes both ways. And I think you're 100% right. And that's why it's important to kind of break down the demographics and understand what is an important aspect to correct, not just race, not just, you know, being Latino or whatever. Like, is it being bicultural from your language background, right? Is it really is your educational quality? Well, going to Cibolo Friends is going to be different than going to a school in Southeast, right? I think we all can appreciate that difference, but our norms don't correct that. Yeah. Well, thanks for all the comments. And yeah, if people have ideas or want to just shoot me a message, always willing to collaborate.